Welcome to the Epilepsy Innovation Roundtable, an exciting on-demand experience created by the Epilepsy Foundation of Michigan for you. I'm Andrea Schottefer, president of the foundation, and I'm so glad you've chosen to join us. This experience is designed to share valuable insights, highlight new and emerging developments in epilepsy care and research, and provide meaningful opportunities for learning. Whether you're watching this on your own, with a loved one, or alongside colleagues, we hope you walk away feeling more informed, empowered, and supported on your epilepsy journey. For over 75 years, the Epilepsy Foundation of Michigan has been dedicated to supporting the 109,000 individuals living with epilepsy in Michigan. From expanding services and growing our team to educating thousands on seizure recognition and first aid, our work continues to evolve. But our mission remains the same: to walk alongside individuals and families every step of the way. We're proud to collaborate with our partners and advocates as we continue to raise awareness, reduce stigma, and create more inclusive communities for people living with epilepsy. This on-demand roundtable experience would not be possible without the generous support of our sponsors. First, I'd like to recognize our presenting sponsor, UCB Pharmaceuticals. Thank you for your continued generous support of our mission. And thank you to our community partner, Trinity Health, as well as all of our network partners. On behalf of the entire epilepsy community, a heartfelt thank you to each of our sponsors. We're so grateful for their ongoing commitment. For all of you tuning in as you move through this experience, keep an eye on the slides featured throughout the session. They include helpful information on how you can connect with our sponsors, learn more about their work, and explore valuable resources they offer for individuals and families affected by epilepsy. Please remember, this is just one of the many ways we support individuals and families across the state. Visit epilepsymichigan.org or call our Here For You helpline at 800-377-6226 to learn more about the programs, services, and support we offer. Now, we invite you to engage with the thought-provoking content ahead. The Epilepsy Innovation Roundtable was designed to highlight advancements in care and explore what's on the horizon for people living with epilepsy. You'll hear from leading voices in the field, guided by our incredible moderators. Now, I'll turn it over to Renee Roederer to introduce our first session. Enjoy.
Hello and welcome to our first session. My name is Renee Roederer and I'm privileged to serve as the Senior Director of Programs and Community Care for the Epilepsy Foundation of Michigan. And so I add my own welcome to the Epilepsy Innovation Roundtable. Welcome. And of course, I'm happy to be here and lead our first session, which is titled Medical Advancements, Innovating Epilepsy Care. Innovation is always reshaping epilepsy care and bringing new pathways to seizure control, broader treatment options, and improved quality of life for everyone who is affected by epilepsy. So today we're joined by two leading epileptologists whose expertise spans both adult and pediatric care. We have Dr. David Burdette and Dr. Seth DeVries. Dr. Burdette brings extensive knowledge in adult epilepsy management, while Dr. DeVries offers a deep understanding of pediatric epilepsy and its unique needs and challenges. Together, they are going to shed light on recent advancements in the field, including cutting-edge medications, neuromodulation devices, and of course, the role of genetic testing, which continues to grow, and evolving models of care as well. So I'm looking forward to having this conversation with both of them and all the ways it will open doors to innovation for individuals and families impacted by epilepsy. So welcome, Dr. DeVries, Dr. Burdette. Thank you for being here with us. Wonderful.
Absolutely. Thank you for having us.
We're delighted. Yeah, and I'm wondering, just to begin, if you would briefly introduce yourself and share one medical advancement or area of research that is currently energizing you. And I realize you may have more than one, but if you could pick just one for now, what's getting you energized and excited in this work right now? Dr. Burdette, how about we start with you?
All righty, I'll jump in. So, what has me particularly excited? I've forgotten the exact term you used, but we'll go excited. Is neuromodulation. So, being able to help patients that previously we were less able to help. So we've had one neuromodulation device that came around in 1997 and was a boon to our existence in the form of a VNS. And then there was a bit of a dry spell. But now we have two more neuromodulation devices, DBS and RNS. And specifically, I'm interested in those two devices applied to stimulation of a deep part of the brain, the thalamus.
Excited to see what will come from that. And
Yeah.
we'll go into more depth with neuromodulation in a bit too. So thank you. Dr. DeVries, what's something that's been energizing you or exciting you in this work?
Yeah, absolutely. I am a pediatric epileptologist, and I spend a lot of time with the epilepsy genetics clinic that we have, and so that is very energizing for me. The advancements that we are seeing with genetic epilepsy, with targeting genetic epilepsies. Precision medicine is a form of treatment that is becoming more and more understood. And sooner than we think, we are going to reach the ability for gene therapy for our patients with genetic epilepsy syndromes.
That is really exciting. And so I'm excited to talk about both of these with you and much more. And just want to thank you for all the work you do. Both of our physicians today are connected to Corewell Health and are serving on the west side of the state. And I'm grateful that you've made yourself available for your patients and, of course, for our whole network. So thank you so much. Also, there have been several new anti-seizure medications approved in recent years. I'm wondering if you can highlight any that stand out to you in terms of their efficacy, seizure control, or maybe making those quality of life improvements. I'm wondering, Dr. DeVries, if we can start with you on this.
Yeah, well, I think what has been really exciting to see for the pediatric neurologists out there is how many of these anti-seizure medications are being targeted for children when it comes to the research that's going on in the clinical trials. For decades, all of the anti-seizure medication research was initiated and started with adults, and then the pediatric neurologist had to take that information and figure out how we would treat a child with that drug. And recently, the anti-seizure medications that are coming out are actually being targeted for children. Some classic examples, or some more recent examples of that, I should say. Epidiolex or cannabidiol is the generic, and fenfluramine are two anti-seizure medications that started out with clinical trials for children with Dravet syndrome. And the results of those studies was so spectacular that we were able to extend the treatment beyond just one particular genetic epilepsy syndrome to adding into that with a condition called Lennox-Gastaut syndrome, which is a very, very challenging epilepsy that anyone who has cared for a child or an adult with Lennox-Gastaut syndrome can attest how difficult it is to get those seizures under control. And then beyond that, now we're starting to see those medicines are being expanded even further to even more medication-resistant epilepsies out there. And I think it's really fun for me to be able to see and say that the children that I'm taking care of are able to receive a medicine that has that FDA approval. With that, I am able to eventually care for these kids until they are 18 years old, and work with the child and their parents for that inevitable transition to an adult epileptologist. And it's been actually an incredible pleasure to be able to actually work with Dr. Burdette on those handoffs for these children, or I should say young adults at that point.
Yeah, I would agree. It's been it was a tough life to be a pediatric epileptologist because every medication that was coming down the pike over the years was well studied, well characterized in adults. But kids are not adults. They're going to deal with medications differently, whether it be on the cognitive aspects or the other quality of life areas, or just bodily with pharmacokinetics. So to see medications come down the pike that have been well characterized in children is amazing. And specific medications that were mentioned, it's we're we're getting some, I want to say, fine-tuned medications with unique mechanisms of action. So Dr. DeVries mentioned Epidiolex, which is pharmaceutical grade cannabidiol, and it started out going down that DeVries pathway, a very difficult genetic epilepsy to treat. But now it is FDA approved for what I want to call syndromic epilepsy, seizures associated with Dravet syndrome, Lennox-Gastaut syndrome, and tuberous sclerosis complex. So it's nice to have some specific medications there. Along Dr. DeVries's interests in genetics, which I love, by the way. I love getting Dr. DeVries's patients when they graduate, because that they have been genetically worked up. And it is amazing what we can identify vis-a-vis appropriate medications or medications that we would have thought would have been helpful, but now we know we don't go there. But other medications, ganaxolone, a medication for a specific seizures associated with a specific disorder, CDKL5, and fenfluramine with Dravet's and LGS. And then on the adult side, and we're hoping that it'll be well characterized on the pediatric side soon, is cenobamate.
That's all really exciting, and just a great example of how people have been working with innovation in order to develop these medications, and then also the ways that communities that are receiving this specific care are also paving the way. Like your own patients are paving the way for this to be studied and for more people to benefit. So that's really exciting. Also, Dr. Burdette, you had mentioned neuromodulation, which I know is a real passion area for you, and you're an advocate for those kinds of devices for people who could benefit, especially those who have drug-resistant epilepsy. So now that you've mentioned that, I wonder if you might just walk us through what those are, how they work, and what types of patients might benefit most from them.
So all three of those devices, VNS, RNS, and DBS, I'm telling them in the order in which they were FDA approved in the US. Those devices are FDA approved for the treatment of refractory epilepsy, and specifically vis-a-vis FDA approval for refractory focal, or by the old nomenclature, partial epilepsy. So refractory we define as seizures that have not responded to trials of 2 or 3 anti-seizure medications. Because once you've tried some appropriately chosen medications, if you're not getting that seizure control that we want, then you start to reach a point of diminishing returns, and that's when we look to devices. Very quickly, the VNS, a little pacemaker that goes over the left chest wall, leads go to the left vagus nerve, and we send potentials, electrical, judicious amounts of electricity toward the brain, and it's going to have a diffuse bihemispheric effect. With RNS, it is a device that is embedded within the skull, so it's flush with the skull surface, and there are 2 leads that go to the part or parts of the brain that are going to be in the network or networks that are producing those refractory seizures. Lastly, DBS is a device, a pacemaker, typically on the right chest wall, and those leads go up and then enter the skull and target a specific nucleus within that deep structure that I'm kind of interested in, the anterior nucleus of the thalamus. Ultimately, in their heart of hearts, what each of those devices do is 2 things. They have an acute disruptive effect on seizures. So when they fire, they break up the seizure. If we're fortunate, they stop the seizure, but they're more effective at breaking it up. So it is shorter and less severe. And the second effect is over time, they train the brain to fire in a fashion incompatible with seizures. So we call that a long-term neuromodulatory effect. And now I'm going to kick it over to Dr. DeVries, because one thing that strikes me is in kids, in children, all of our brains are designed to learn new information. But children's brains are really set up to learn new information. And they can learn good information, they can learn bad information. And seizures are bad information. So that those networks in the brain can train that brain to have seizures and train other areas of the brain to have seizures. So it seems to me that these devices, though 2 of them are only FDA approved in adults, there's an extensive VNS literature and experience to show that children in particular do well with these.
Yeah, I absolutely agree with that. I think something that's really exciting, and we have the literature to support this as well. With the VNS is how some of the intangibles that you can't really measure. You can measure how many seizures a person has. You can measure how long the seizure lasts. But some of the other stuff that families will oftentimes report is that with this type of neuromodulation, their children are more alert. They're more aware. They start to perform better in school. They're retaining more information. So just like Dr. Burdette said, right, the brain is learning good information and bad information. And, this is because of this neuromodulation, it's allowing these young developing brains to receive and develop all that good information.
Yeah, it's interesting that over the past few years, there's been a shift in our focus of, let's call it epileptic or epileptogenic phenomena. That I like to tell the residents and the fellows who train with us that ultimately we're in the quality of life business. And Dr. DeVries is hitting the nail on the head. It's those intangibles that really define you. And seizures are a significant determinant of quality of life, but they're not the only determinant. In fact, over the course of the day, we spend more time with interictal or between seizure bursts of activity than we do in seizures. And we're finding over time that when we see that improvement that Dr. DeVries has seen in his kids with VNS, and in the adult side with our DBS and our RNS, that those improvements are correlated with a reduction, not just in seizures, but more so with those interictal or between seizure bursts of activity.
That's wonderful because, like you said, this is about quality of life. And of course, that is about reducing seizures as much as possible, but allowing for all the things we would want to be able to do and learn and grow. And so thank you for all the work you do around that. And Dr. DeVries, we've already touched on just a bit on genetic testing, naming that as a real area of innovation. And we know that all of the research and all of the growth in genetic testing has been remarkably innovative area for epilepsy care. So how do you use genetic panels in your practice, and how are they shaping diagnoses, treatment strategies, and things like that?
Yeah, great question. I think, first of all, just about every child with an epilepsy syndrome should be evaluated for a genetic cause. If you are seeing a person and they, especially if they are presenting with some other symptoms besides just seizures, if they're presenting with developmental delay or cognitive impairment, or even regression in their development or behavior, genetic testing should be something that we think about immediately. And there are a variety of different ways that we pursue genetic testing. In the world of epilepsy, one of the most common types of panels that we utilize is referred to as a comprehensive epilepsy gene panel. And essentially what this does is collects the patient's DNA, and it is specifically targeting over 300 different types of genes that we know can be responsible for seizures. And when we do this testing, we look at that, and we are essentially looking for one of possible 4 answers. One of those answers can be, we've tested all 300 genes and everything is negative. Not a single one of these is the reason why a person that you are having epilepsy. Another possible answer is positive. We tested all 300 genes, and this particular gene is the reason why you're having seizures. And when that happens, we can start looking at treatments, and we can target our treatments depending on what that particular gene is. For example, we've mentioned CDKL5, and ganaxolone is a targeted medication for that. Or SCN1A is where we can target with fenfluramine and cannabidiol, and we avoid certain medications with SCN1A. Sodium channel blockers are the medicines that we avoid. Or SCN8A, where sodium channel blockers are particularly helpful, or CDKL5 or CACNA1A or GRIN2A. It's alphabet soup in the end. Another possible result, though, can be benign. We've tested all these genes, and hey, you know what? This one is abnormal. But we know that abnormality doesn't do anything. It's not a problem. So it's benign. And then the 4th possible answer is what we refer to as a variant of uncertain significance. All these genes have been tested. Hey, this one's abnormal, but we don't know if it's a problem. We don't know if this is the reason why or not. We need more information. And because of that, it is so important that when we are pursuing genetic testing, we need to be in good communication with our colleagues in medical genetics. We need to talk to genetic counselors and the geneticists, the physician geneticists as well, because their expertise in how to pursue the testing, what types of testing should be considered, what to look for with the particular genetic conditions is vital to making sure that we are providing not just epilepsy care, but we want to care for the entire person. Whole body care is important with all of this.
Yeah, that's so wonderful. And it's exciting to see how perhaps people, even decades ago, that might have had one of those variants of unknown significance, later we do come to know more. And that's really exciting to be able to chart that progress. So thank you.
Yeah, absolutely. I think we see this all the time, and where something was previously classified as unknown, later is classified as pathogenic or maybe benign, depending on the results. And for that reason, we do always encourage repeat testing every 2 to 5 years in case there are those questions, if we don't have an answer. That should also come with continued interaction and communication with our colleagues in genetics. Another thing that I would like to bring up, though, is the exciting progress that we have made with the testing beyond just these gene panels. We have the ability to pursue or to perform whole exome sequencing or even whole genome sequencing, and that is specifically important for our patients in the neonatal intensive care unit. When I see a baby who has been born and is having seizures almost immediately, I can work with the genetic specialists, and we can pursue what we refer to as rapid genome sequencing, and we can send the DNA and get the results. What normally would take several months to receive comes back within a matter of weeks. And in doing so, again, we can target the therapy and recovery and treatment for these babies. And the result there is significant, not only improvement in quality of life, but we're saving the brain when we can do that, right? Some of these children, if they're having seizures over and over and over again, they are losing the ability to learn, to grow, to develop. And if we can shut those seizures down, if we can figure out why and treat them quickly, we can provide, a lot of growth down the road for them.
Yeah, and just that impact can last really lifelong if we can engage very quickly. So I thank you for that. Dr. Burdette, what are some new questions you find yourself asking on the frontier of epilepsy care? Definitely tell us about the anterior nucleus of the thalamus, but anything else that is kind of a new question for you or an ongoing question you think about a lot?
Well, I think all too often about these things because there's so much I don't know. There was a British physicist, Emerson Pugh, who is reported to have said in so many words, if the brain were simple enough for us to understand, we would be too simple to understand it. So it's an uphill battle for us to understand the neurochemistry, the networks that underlie what makes us who we are, which is our brain. Nevertheless, we are getting insights, whether it is with the newest technologies in the epilepsy surgery space. The world has shifted toward SEEG, stereotactic EEG, which allows us to better define networks that are involved in seizures, but also networks that are involved in normal neuronal function. So just we are learning by leaps and bounds, and this translates to the treatment of epilepsy. So I muse that what I routinely do now to help patients with epilepsy is far beyond what I was doing 5 years ago, which in turn is far beyond what I was doing 5 years before that. Vis-a-vis the thalamus, one of my favorite topics, but the two quickest ways to get people to leave, if they leave the room, is to yell fire or to threaten to talk about the thalamus. So the thalamus is this structure that is deep in the brain, and 4 out of our 5 senses, so vision, auditory, somatosensory, and taste, are all, when they come into the brain, filtered through the thalamus and then sent to the correct area of the cortex for us to for that to reach consciousness. And then there's a return signal sent, and more signals are sent to broader areas. The upshot of this is the entirety of your cortex has reciprocal connectivity to the thalamus. What do I mean by reciprocal? There are neurons that are sending axons or connections to specific thalamic areas and getting a return signal. So we have a network, we have a loop. But the thalamus is not uniform. It is very complex. So there were thoughts back in the day that the vast majority of seizures were temporal lobe. And many seizures are temporal lobe, but perhaps not as many as we once thought. So the temporal lobe is part of our limbic system, and that has to do with our emotions, our memory, and whatnot. And there's a network that goes through the limbic system that involves a specific thalamic nucleus, the anterior nucleus of the thalamus. So that's why this was targeted with DBS. But we also have some other thalamic areas that go well beyond the limbic system. And as our technology has gotten better and better at identifying where those networks are, we're finding that they may or may not involve the temporal lobe. And when they don't, they're going to be networked to other parts of the thalamus away from the anterior nucleus. So I'll call it the ANT for short, anterior nucleus of the thalamus. And we are doing active investigations now to target these specific thalamic areas that are involved in each individual's seizure generating network. So it's a form, let's say, of precision medicine. It's not really genetic precision. Yeah, Dr. DeVries does the cool stuff with the genetics, but it is an individualized targeting, and it involves the thalamus, but not just the ANT. In fact, we were the first in the world to permanently implant a thalamic nucleus called the pulvinar. The pulvinar, the largest of the thalamic nuclei, it's connected to our visual centers. As humans, we are visual creatures, and the pulvinar is the visual thalamus. So there's a lot of exciting work looking into, let's fine-tune this targeting. I do want to say, just as an aside, that vis-a-vis Dr. DeVries and the whole genetics team at Helen DeVos, generally in the treatment of epilepsy, when I think of anti-seizure medications, I think of anti-seizure medications, medications FDA approved for the treatment of seizures and whatnot. But it is so interesting to me that when their team identifies some of these unusual combinations or individual genetic mutations, that they will utilize drugs that have nothing, as far as I can tell, to do with epilepsy. But because of that genetic information, they integrate that into the treatment paradigm, and it works. I don't know. I'd love to hear him expound on that, because that
Yeah,
just
anything you
blows
want to
my
add?
mind. Yeah.
Yeah, well, I will say there are a couple of genes, epilepsy syndromes, genetic epilepsies that I know that ongoing research is happening in multiple different institutions and various sites that are looking at how the gene itself and that gene mutation results in an abnormally shaped protein, and that abnormally shaped protein then affects the process of amino acids. And so a lot of these genetic treatments that are being used are specifically targeting how can we address that particular amino acid and target it. An example would be a gene called SLC6A or SLC26A. And it is looking at just that. It's looking at the metabolic process in all of this, targeting the amino acid, targeting the actual metabolism that's being involved. And the research is still ongoing. There's still a lot that has to be done before we can actually say that that's what we're going to be able to, successfully do. It's encouraging to see that. We're seeing the same thing with a condition called GRIN2A, and treatment for that depends on us, frankly, if it's a gain of function or a loss of function with the gene itself. And if we see gain of function, we can use a medicine called memantine, which is not normally used for seizures. And if it's a loss of function, we actually can recommend sometimes we refer to it as an amino acid cocktail. But essentially what we are doing is providing the body with some of the amino acids that it wouldn't otherwise be able to utilize. Gain of function versus loss of function also affects how the person is going to present clinically. Are they, what types of seizures are they experiencing? Are they experiencing concerns with their development and their growth and their behavior? Or are they experiencing more challenges with the seizures themselves?
This is great. I think back to 40 years ago, right? And how few, there were some options, right, for epilepsy care, but we're getting to this era that, as we know more and more, how targeted we can be. If these conditions are present, then here are our options. And likewise, whether that's based on genetics or kind of our unique wiring in our own brains. And this is a really exciting time. So thank you so much. A different question altogether, but maybe connected to some of this. Dr. DeVries, can you share a little bit about the importance of neuropsychological testing in pediatric patients, and what insights are research studies showing about epilepsy, cognitive function, maybe some comorbidities like ADHD?
Yeah. So, I've mentioned a couple of times how patients with epilepsy can frequently struggle with learning development and behavior. And ultimately, neuropsychological testing looks at all of those concerns. Our colleagues in neuropsychology will help us out by performing these tests, and ultimately are identifying, okay, well, what is the child good at? What are they not so good at? What do they need help with? It's more than an IQ test. It's more than assessing their ability to retain information or a memory test. They're looking at all of the person, so that they can provide some insight on who is this person, how do they think, how do they learn, and what do they need. This has been incredibly important in epilepsy, because we know that with ADHD in particular, ADHD is 2.5 to 5.5 times more common in children with generalized epilepsy compared to the average person. So this is something that is significant, right? And we need to keep that in mind when we are caring for our kids. We need to keep that in mind for our epilepsy patients, to make sure that we are not losing that or ignoring that. Our patients with absence epilepsy, these are seizures that, if left untreated, a child can have them dozens of times a day. And they're so short, they're so brief. The child is just having this moment of staring and unresponsiveness that can last for seconds, 30 seconds at most. But they are happening over and over and over again. And if you are losing 10 to 30 seconds of your time every single day for dozens of times a day, it's going to be very, very difficult to learn. So we get those treated. We treat that with medicine. Yet, if that child is also 2.5 to 5.5 times more likely to have ADHD, we cannot ignore that either. And so now we have a patient who is very, very well controlled for their epilepsy, but maybe they're still having some staring spells. But this time it's not a seizure. This time it's that inattentiveness, right? And if we don't recognize that, and if we just start throwing more medicine at the child who is already well covered, but we don't understand it, all we're doing at that point is over-medicating a person, subjecting them to potential side effects, and doing them a disservice. When we know that both can be there, we can address both of those issues. Neuropsychology is extremely helpful with that. Recognizing this and regular screening for conditions like ADHD are very helpful for that as well. And then I can go further and say, even when a child has outgrown their epilepsy and it's gone, their risk for learning disabilities, their risk for ADHD still exists. And one thing that I'm very passionate about is making sure that my patients are prepared for that, prepared for life, prepared for their career, prepared for their independence. And so testing, preparation from not only from an academic side, but also from a social side and a vocational side of things is vital to them as well. I can go on and spit more literature at you and more statistics, but what we do know is that adults with a history of childhood onset epilepsy, frustratingly so, have overall a higher unemployment rate and a lower level of education, or a lower likelihood to pursue higher education, and a lower overall annual salary compared to patients or adults without epilepsy. Now, this study was done several years ago, and this study was looking at current adults. So we know that now, and so therefore we can start acting on that for our current children, so that they are prepared and they are ready, and so that they will not have the same risk factors, and they will be more prepared for success.
That really touches me. I just want to say, because I think something that's really come through in our conversation today is, yes, part of the work of innovation is learning those research studies and looking at that literature and asking new questions. But honestly, it's also driven by truly the care that you and also your other colleagues have in wanting people to live well, right, as well as they can, and to have options, to have choices in that, and to be who they are uniquely. And so thank you for all the ways that you have mentioned that today, and just, encouragement for anybody watching to say that that's what we're all about. We want you to have that quality of life and the joy of living and learning in all the ways that you want to. And so thank you for bringing that up. And speaking of, all the ways that we deliver care, care delivery itself in medicine evolves too. And I'm curious whether through its telehealth or working collaboratively or other kind of models, how are you seeing access improve, or maybe some outcomes, improve, just even in the care delivery process itself? Either one of you can start that question.
I'll jump in. So I think telehealth has been a boon to our existence. There probably was not a lot of, there were not a lot of positives that came out of the COVID era, but some did. And one of those positives is the embracing of telehealth. And I think in general in healthcare that it has been an important addition to our ability to see patients, address patients' needs, but particularly in epilepsy, where patients may not be allowed to drive. And just these simple restrictions have far-reaching consequences, one of which is it is difficult to get to a clinic visit. And if we can do that in a virtual fashion, then it makes a world of difference. So patients who live in the upper part of the Lower Peninsula, patients who live in the UP, where it is a haul to get to any epilepsy center, we can now address most needs through telehealth. So technology has worked in our favor in many ways.
Improves access. Dr. DeVries, anything you would add?
Yeah, I absolutely echo that. The telehealth has been incredibly helpful, both for the patient and the epileptologist when it comes to it. And yes, as Dr. Burdette was saying, the distance and the limitations with driving or the time to travel is an incredible barrier. I would also add that, when a patient is non-ambulatory, if they're if they're stuck in their bed, if they have cerebral palsy and their caregiver, the amount of work that it takes for a caregiver to move that patient to the wheelchair, load them into the car, and then drive them to the clinic, unload them, get them prepared, make sure that their oxygen and their feeding tube and everything else is ready, wheel them into the clinic for a 30-minute visit, and then wheel them all the way back. It's impractical. And if we can make that their life just a little bit easier by doing this with a virtual, then why not? Let's do that.
Yeah, thanks. And I'll just also add from a public health perspective, this is sort of a jargony term, but you'll hear people talk a lot about social determinants of health. And I think it's been really helpful to see physicians and public health workers use that language, meaning, what are some of the social dynamics or barriers people are experiencing in their lives, whether it's food insecurity or a lack of housing or affordable housing, employment, transportation systems, right? All of these kinds of realms of our social life that actually may impact us quite a bit in the level of health that we have and the level of health access that we have. So I've been seeing that language, but also, the determination to address those become a real part of what we do. And I hear that a lot in our Epilepsy Foundation network. And it's something that we think about a lot. And so I would say that has been innovative as well. And speaking of that, what are some other current barriers or limitations that you see in epilepsy care that you would hope to overcome with future innovation? If you could fix anything, what might it be?
Wow, what a loaded question there.
Yeah. In your dream world, yeah.
Yeah. Well, I will say this. I think that certainly access is a limitation. And I will say that access is a limitation from a variety of ways. Yes, it's the travel and the driving, but also there are not enough of us. And there's not enough neurologists, let alone epileptologists, let alone pediatric neurologists. And so anything that we can do to encourage and train the future generation of epileptologists is something that I'm very supportive of, and excited about, to be able to work with the next generation of physicians, my future partners, right? So that would be something that I would love to continue to see grow, and I am seeing it grow.
Yeah, I would agree that epilepsy is a very niche area. It's neurology in and of itself, the study of the brain, the treatment of disorders of the brain is a niche area. You almost have to dedicate in a blinders on fashion your professional life to doing this. So now we take a subset of those individuals with epilepsy, and as we know, there are many people out there who have epilepsy, but they need that specialized care. And there are not enough of us out there. So until we can rectify that, we are highly reliant on a well-trained cadre of advanced practice providers. So our physician assistants, our nurse practitioners have become just invaluable in the clinic, because they too gain this very focused amount of knowledge, and without them, access is impossible.
Yeah, so we're so thankful for them. And I would say to anybody who's thinking about this as a career, at the level of neurologist or epileptologist, or all of those other people you just mentioned, the medical assistants and nurse practitioners, we know epilepsy can really disrupt a quality of life for a person and for a family. And so, but it is an area where really doing that care, like, you're going to make a difference every single day. And so I think, both of our physicians today and all the ways that they're doing that, but also everyone that helps you on your teams, because we hear from patients and families how their lives are different and changed because they found the right place or the right center for them, the right treatment for them. And it is amazing. And with that, just kind of lifting up that kind of positive hope for our people in our community out there, what encouragement or hope would you offer people living with epilepsy and their loved ones? If you were to give a little pep talk right now, what might you say? Dr. Burdette, how about we start with you?
Sure. So if I were to make a closing thought, I would say never give up. And particularly, don't give up the struggle, but don't give up hope, because there are so many advances that are happening. We're doing 2 studies, one of which involves, with temporal lobe epilepsy, injecting a gene therapy that will alter the receptors that cause epileptogenesis, the seizures, to learn how to have seizures. And also another study that involves stem cells that have been programmed to go toward inhibitory interneurons, inhibition decreases seizures, and the early results from these are very promising. And this is just the tip of the iceberg. So as I was saying, what I do now routinely, I wasn't even sure I was thinking of doing 5 years ago, and so forth, going back in 5-year increments. In 5 years, we're going to be well ahead of where we are now.
Super exciting. Dr. DeVries.
Yeah, I think I've got two things that I would like to say to anybody who's listening. The first is you are not alone. Sometimes epilepsy can feel very isolating. Everyone here is can stand up and say, you are not alone. You are not walking this journey by yourself. There is not only is there a team of people who are supporting you and your loved ones, but also there are innumerous number of people who share your condition. Right. We say it all the time. 1 in 26 people will have a diagnosis of epilepsy at some point in their life. 1 in 26. And that is a lot of people. And when I talk to my patients about that, I tell you, imagine a classroom. Imagine how many kids are in that classroom. Probably about 25 to 30. Yeah. That means that statistically, there is a student in every single classroom in America who either has had epilepsy, does have epilepsy, or will have epilepsy, and you are not alone. Right? And to add on to that, do not let this diagnosis define you. Right? You are more than just your diagnosis. You are so much more than that. There are so many people with this diagnosis. There are so many people who have succeeded and thrived with this diagnosis. Right? Famous people with epilepsy, right? NFL quarterbacks like Justin Fields, right? An NFL quarterback, formerly played for the Chicago Bears, is now the quarterback for the New York Jets, has epilepsy, was diagnosed when he was 15 years old, and is an NFL quarterback. Musicians like Prince or Lil Wayne, actors like Hugo Weaving, right? Authors like Lewis Carroll and Charles Dickens. I mean, you too can lose to the Lions by 1 point, right? That's what we're saying here.
Yeah, thank you for that. And just for everybody to know, like, you have a whole team here. And I think one of my takeaways from this time is we're all doing innovation, right? Whether we're the doctors or the patients or the community leaders and the friends. Because I mean, I'll tell you, I often take our calls for our Here For You helpline. And this is my 7th year at the Epilepsy Foundation of Michigan. And I still get questions I've never gotten before. You're helping me innovate. You're helping your doctors innovate. Just being yourself, and that this is something we get to do together. And I can't wait for when we're 5 years down the line and we can remember where we were now. Already excited about much, but even further ahead. So I absolutely want to thank Dr. Burdette, Dr. DeVries, for sharing your insight, your expertise, and also your passion for doing this work. And I'm so grateful for all that you do at Corewell Health. Helen DeVos Children's Hospital, all the patients you see in Grand Rapids. And this has just invited us to continue to think about collaboration. You all are both a dynamic duo. We can see that today, not just on a presentation, but the work that you do. So throughout this on-demand conference, we're going to keep the conversation going and continue working together toward a world with more answers, more options, brighter outcomes. And speaking of that, in our next conversation, we are going to be talking about transportation. And so we invite you to stay with us, tune in for these next sessions, and we're going to keep exploring the future of epilepsy. Thank you so much.
Thank you.
Thank you.
Hello and welcome to the second session of our Innovation Conference. We are so glad you are here. My name is Nicole Fitzpatrick, and I serve as the Community Program Specialist with the Epilepsy Foundation of Michigan. I'm also the mom of a young adult living with epilepsy. At the foundation, we understand that having a diagnosis of epilepsy is about more than seizures. The diagnosis impacts all facets of life. The foundation is committed to the idea that nobody walks this journey alone, and we want to help provide education, outreach, resources, and advocacy to help people live their best lives. Did you know that each year the foundation selects a challenge of the year? This serves as a cornerstone initiative through which we focus our efforts on addressing a significant epilepsy-related issue impacting individuals and families across our state. The theme guides our work in education, advocacy, and public awareness. It's an opportunity for us to listen closely to the needs of the community, elevate stories, and spark collective action. We invite you to not only learn more about the issue at hand, but to join us in driving meaningful change. I'm excited to introduce this next session because it is in honor of the Epilepsy Foundation of Michigan's Challenge of the Year for 2025, which is transportation. Transportation is something many of us may take for granted, but for people living with epilepsy, it can be a major and deeply personal barrier. Currently in Michigan, individuals are required to be seizure-free for at least 6 months in order to drive. While this law is in place to protect public safety, it can also create significant challenges in accessing employment, medical care, education, and even maintaining social connections. For many, it impacts independence and quality of life on a daily basis. So here are a few highlights of what we've been working on related to our Transportation Challenge of the Year. Advocacy. Every state has its own rules when it comes to who can get a driver's license, especially for people with medical conditions like epilepsy. These laws are meant to keep everyone safe on the roads while still allowing people the chance to drive when it's safe for them to do so. In most states, someone with epilepsy needs to be seizure-free, specifically free of seizures that affect awareness or consciousness for a certain period of time before they can get a license. That seizure-free time varies from state to state. The Epilepsy Foundation of Michigan supports House Bills 4306 and 4307 because they strike a good balance. They help keep both the public and the individual drivers safe, while also giving more independence to people with epilepsy who are safe to drive. I'd like to tell you what the legislation includes. To begin, these bills align with recommendations from the leading medical organizations like the American Academy of Neurology, the American Epilepsy Society, and the National Epilepsy Foundation. They include a minimum seizure-free period of 3 months, with additional consideration of certain factors that might shorten that interval. For example, if the seizure happened due to a doctor-guided medication change, if it was a partial seizure that didn't affect consciousness or driving ability, or if the person only has seizures at night while sleeping, these could all be factors for consideration. The legislation also includes a continued role for the treating physician who provides important medical information so licensing decisions can be made fairly and independently. And it ensures that individuals are given notice and the chance for a hearing before their license is suspended. We thank Rep. Kurt Vanderwall and Rep. Nancy DeBoer for their leadership on this issue and offer the Epilepsy Foundation of Michigan support for House Bills 4306 and 4307, which aim to help as many people with epilepsy as possible remain independent and drive safely. You can learn more about this and other advocacy efforts on our website, epilepsymichigan.org, and the link to our advocacy page will also be provided in the notes section of this video. In the areas of education and resources, people contact our Here For You helpline for a variety of reasons, and we aim to support them by providing a listening ear and connecting them to resources. One of the topics we hear quite often is that they are looking for transportation alternatives to access doctor's appointments, employment, or other social engagements. So as we researched transportation resources by community, we started putting together a list from those various communities. Through this research, we learned that another organization, Disability Rights Michigan, was doing the same thing, and they were able to take it a step further by creating a statewide resource map. Today, we're going to hear from Kristen Milefchik about the creation of this tool, as well as how to navigate it. And talk about innovation, we recently had the chance to be a part of a really exciting research project about autonomous vehicles and epilepsy, led by Dr. Diane Peters, an associate professor at Kettering University. The foundation helped organize both one-on-one and focus group discussions to explore how new vehicle technologies could better support the independence and transportation needs of people living with epilepsy. During these meetings, some of the topics discussed included what kinds of driver assistance features might make it possible for someone with epilepsy to drive safely. As fully autonomous vehicles are developed, what specific considerations should be made to ensure they're accessible and safe for people with epilepsy? And how would people access these vehicles? Would they own them or prefer an on-demand service? It's an important step toward understanding how innovation in transportation can help improve quality of life and independence for individuals and families affected by epilepsy. A special thank you goes out to Kristen Milefchik and Dr. Peters for their work, and stay tuned because next we are going to hear from them directly to learn more about their projects. Thank you.
Hello, everyone. My name is Kristen Milefchik, and I am here to talk to you about the Disability Rights Michigan Transportation Guide and Interactive Map. It's an honor to be here with you today. I have a disability myself. I'm a lifelong wheelchair user, but I'm sure as all of you know, transportation challenges are something experienced by many people both with disabilities of all types and without. And so it's exciting for me to be able to talk about this tool that we developed and about innovations in transportation because it's such an important issue. So I'm going to start by talking a little bit about Disability Rights Michigan. We are Michigan's federally designated protection and advocacy organization. That means we're part of a national network. There is a protection and advocacy organization in every state and territory in the United States. We're funded by 9 federally mandated programs as well as state and private donors. We serve the entire state of Michigan, and we receive over 4,000 calls per year. The transportation landing page was really a product of the work we did on the vaccine advocacy program. The vaccine advocacy program was a time-limited outreach and advocacy program funded by federal and state grants to help people with disabilities, their family members, and caregivers get vaccines. And this project aimed to better understand the barriers facing people who have lower rates of vaccinations, partner with communities to help people get vaccinated, improve access to vaccines, and improve messaging around vaccination. One of the things that we did that really made this program a success was partnering with other organizations, community-based organizations, and other disability service organizations, as well as with mobile health units to bring vaccines and healthcare services to people where they were, rather than asking them to come to us for the services they needed. And us being out in these communities, talking to people where they were allowed us to gather some really important information about what the regular barriers to healthcare and vaccines were. And that called on us to formally address those barriers and come up with some long-term sustainable solutions. So as you might have guessed by now, one of the main barriers that we did discover in our research and our fieldwork was transportation barriers. And we found that through a variety of ways. First of all, qualitative data that we gathered, and this included responses to surveys that we did, one-on-one clinic interviews where we actually talked one-on-one with folks that attended some of those vaccination clinics out in the communities, focus group discussions, and all of these showed a pattern of transportation being a top-cited barrier to accessing vaccines and other healthcare. We also did get some quantitative data that also supported this need. For example, almost all Michigan residents, 97%, live in households with at least one car, but 11% of Michigan residents with disabilities do not own any cars. Having all this data made it clear that people needed a tool to be able to find the most accessible and affordable transportation that was available in their geographic areas, and that's how the Transportation Landing Site was born. Since its launch in February 2024, the DRM Transportation Landing page has reached over 310,000 individuals across Michigan, and it remains one of the top 3 most visited landing pages on DRM's website. You can find the DRM Transportation Guide by going to the main website at www.drmich.org, and then go to the Resources tab, and the Transportation Guide is the first option on that drop-down menu. You just click that. And then on the Transportation Guide site, you actually have a few options. There is an overview, the transportation map, transportation advocacy, frequently asked questions, and share your transit story. We want to go to transportation map since that's the main tool that we're discussing today, and then click Visit Interactive Map. Okay, and so here we are on the transportation map page, and you'll see that there are 2 different views, the map view and the list view. The difference is that the map view, you can actually see a map of where these different transportation services are. So if you prefer that sort of visual, for instance, you could say that you live in the Traverse City area and you see some bubbles here, and you just put your mouse over that, and that says Bata Village Loops. You can click on that and actually go straight to that service. So let's go back to the map and go to the list view. And the list view works the same way as the map view, except that it just doesn't have the picture, doesn't have the map. It has the text listing of all the different transit agencies, and you can search by city, zip code, or keyword, or you can use these filters that are built in. You can filter by county. So let's just go to Oakland County, see what pops up. It says 10 listings for Oakland County, and then you can narrow that down more by the mode, transportation mode. So there are 8 that are demand response. That's the door-to-door service. You have a fixed route service and paratransit service. Let's just hit fixed route and see what comes up. So you have the smart fixed route service in Oakland County. And this is what happens when you click more info. More info brings up detailed information about that transit service, and does so for any transit service we have listed. And we have this convenient navigation bar at the top. So instead of scrolling down through all this information, you can see up at the top, you can skip right to the information that you want to see. So let's say you don't know what the fares are for this service. You just click fare. It's going to tell you what the standard fare is and what the reduced fare amounts are. You have your accessibility and eligibility information. So it's going to tell you, whether the buses have lifts or what other accessibility features they have, what you need to be eligible to use the service, etc. And then at the bottom of the page, is provider information. And that is the overarching transit agency for that provides that service. And it always has contact information. And there's usually a website that they have of their own. So you can go to visit web link and it will bring you straight to their website. Don't forget to check out our other features on the transportation guide. Transportation advocacy has a ton of great resources. We have a lot of helpful organizations listed here that are involved with transportation advocacy and information about how to file complaints. Also, keep an eye out for future changes to the website. Some enhancements that we're considering for the future are to collect some information from transit users and others about what improvements can be made to the current transit system in the form of a survey so that we can better advocate for improvements to the system. We know that even though public transit is the best option as far as guaranteed accessibility and affordability, that there's a lot of room for improvements to be made. So we want to get some specific feedback about the challenges that people face using transit. We also are considering adding a latest news and events section to inform people about what's going on behind the scenes of public transportation and how to get involved. So legislative and or budgetary decisions, volunteer and advocacy opportunities, educational or informational opportunities would be listed in this section so that people can get involved and advocate for more and better transit in their communities. Make sure that you also reach out to us if you have any questions or recommendations for improvements for the transportation site. You can see our contact information here, and we always welcome feedback. Thank you so much for your time, and I hope you enjoyed the presentation.
Hi, I'm Dr. Diane Peters. I'm a faculty member at Kettering University in Flint, Michigan, and I'm going to be talking about epilepsy and autonomous vehicles and about how they can remove barriers to mobility. This is a result of a study that I did in collaboration with the foundation this past year, and I hope you'll find it interesting. So first of all, what am I going to be going through? I'm going to talk about the overarching goals. Why were we doing the study? What was the whole purpose? The specific questions that were asked, how it was conducted, and then the really important and interesting part is what was found, and then what are the next steps that are coming. So the goal is this: all people, and that includes people with epilepsy, should have full and complete access to safe and effective transportation. And that is extremely important because this access will serve their needs, allow them to live full and complete lives. This includes transportation to the workplace, running routine errands, medical appointments, and recreation, which is part of life and an important part. Now, this is not currently the case. As I'm sure you know, many people with epilepsy face transportation challenges, and these challenges need to be fully understood so that new technology can be used appropriately. We're developing huge amounts of new technology. It can be a huge benefit, but it's got to be done right. So specifically, I'm talking about autonomous vehicles, either fully or partially autonomous, and they are coming. You've probably seen studies out there. You've seen reports in the news. People are testing them. There's a lot of questions about when they'll be safe enough to see widespread use. That's a really good question. But the major automakers and some very small companies as well, some startups, are all working on them. There are students, such as the students I teach, who are studying the relevant technology. They're learning about it in engineering programs. They're working on competition teams. I advise a competition team here at Kettering, the AutoDrive team, that is working to make a vehicle in a competition autonomous. But there's still a question here. are these autonomous vehicles truly going to address the challenges faced by people with epilepsy? Is it enough simply to make the car drive itself and call it good? Spoiler alert, no, that's not enough. Just making the cars drive themselves is not enough to make them truly a good solution. So in the study, there were some questions that I was asking people. And there were two sets of questions based on whether I was speaking with people with epilepsy or healthcare professionals. And when talking to people with epilepsy, I had basically 4 questions. As you can see, some of them have multiple parts. The first one was just, how do you handle transportation? Are you able to drive? Does somebody drive you? Is public transit an option? Second one had to do with accessibility. How accessible do you feel transportation is to you? And along with that, do you sometimes have to forego going places you want to because of transportation? Third question really started to drill down into the specific impact of epilepsy. In what ways specifically does epilepsy impact your ability to drive or to use other forms of transportation? And then the last question was kind of a broad one, which could be answered in a lot of ways. What would an ideal transportation solution look like to you as an individual? And that question got answers that were different because of different people's needs. Now, healthcare professionals have another perspective, and it is also extremely useful and valuable. They do not, in general, have the experience of living with epilepsy, but they interact with people, they treat them, they see the problems from the other side, and they see a wide variety of people. So the first question was, thinking about your patients with epilepsy, how much of a problem is transportation for them? And what challenges do they face due to epilepsy with either driving or with public transportation? And then second, what kinds of transportation solutions would work with the average patient? And then, since not everyone is average, what would be necessary for the worst case scenario? Third question, what types of actions should an autonomous vehicle take if someone in it has an epileptic seizure? Are there actions an autonomous vehicle might take that would trigger seizures in some patients? That's also an important question because we don't want to make problems worse. And then the last question. This was kind of a fun one to discuss and to brainstorm. If a vehicle was to have a system to detect a driver or passenger who had a seizure, how might it work? What could it detect that would indicate a seizure was taking place? So these are all very important questions for both groups. Now, how was the study conducted? Well, first of all, the Epilepsy Foundation of Michigan recruited the participants. The foundation has a wide network, was able to reach out to a lot of people. There's no way this could have been done without them, and I'm very grateful for the support. And then individual interviews and focus groups were conducted over Zoom. So in some cases, people wanted an individual interview. They wanted to talk one-on-one. They didn't want to be in a group. Other people were a little bit more amenable to a focus group, having more than one person, having some back and forth with others. So both options were offered, and people could choose whichever one they thought they were most comfortable with. Staff from the foundation coordinated the Zoom sessions and took notes. And again, that's something I'm very grateful for because it makes it much easier to have a second person taking notes. Now, what did we find? Well, it is no surprise to anybody. Many people with epilepsy do have transportation issues. This is not a surprise to anybody who's watching this presentation. And these issues affected their ability to work. Some people were limited in where they could get jobs. Some people were unable to work because they could not get reliable transportation to their job. It affected school. Do you live on campus? Do you commute to school? How does that work? How do you get to class? Simple things like visiting friends. Some people were very isolated because their friends had to come to see them. They didn't have a safe and effective way of getting to see them, and that really affects quality of life. Simple things like just going to the store were also an issue. Yes, there are many delivery services, and we can have a lot of things come to our door, but sometimes you just want or need to go to the store to see things and pick them out for yourself. Healthcare professionals reported things that really aligned with what the people with epilepsy said. They reported many patients have issues with transportation, and one of the things they saw in particular was getting to appointments. That affects their ability to actually control and treat their epilepsy, to have their best possible medical results with it, because sometimes they just can't get to the doctor. Now, public transit may be a solution at times, and some people reported that they had access to it, but that also has challenges. One of the questions that came up is, what if somebody has a seizure on the bus or the train? On the one hand, the driver of the bus or the conductor of the train probably isn't trained, doesn't know what to do, may be busy driving the bus and can't do anything. And then, of course, there's also the sad fact that if somebody is helpless due to a seizure, there are some people who will commit crimes. There are people who will rob them, who will take their wallet. There's the possibility of somebody falling because they have a seizure and ending up in harm's way. So that is not itself a perfect solution to the problem. Now, some communities, as reported by some of the people who I talked to, have services similar to Lyft or Uber. And some people simply use Lyft or Uber. But there are also services out there, which is good because the money aspect is important, but they may not cross county lines, or they may have other limitations. So if somebody lives in one county and works in another, and they're trying to get to work, what do they do if one of these services can't cross the county line? Do they wait by the side of the road? That's not a good solution. So the overall conclusion is that fully autonomous vehicles, or vehicles that have partial autonomy that could take over in an emergency, could be a solution. And that's something that many people, both among those with epilepsy and the healthcare professionals, felt was the case. Now, two important questions arose here. And one of them was asked to the healthcare professionals. And it was one where there was a lot of discussion. But the other one arose naturally in talking to people with epilepsy. First of all, how could a vehicle know that a person, either a driver who's actively driving or a passenger in an autonomous vehicle, was having a seizure? And then, what should the vehicle do if someone is having a seizure? Say it can detect it. Now what? Now, that first question on a technical level is extremely challenging. And it's challenging, first of all, because seizures vary a lot. Anyone who has talked with a number of people with epilepsy knows that their seizures are not all the same. So a simple visual identification technique with cameras and some kind of neural network AI training may not always work. Now, in some cases, you might be able to detect it through an abrupt, unexpected movement. Say the person suddenly jerks the steering wheel or pushes the brakes. But then again, sometimes those are exactly the actions you need to take when driving because there's some emergency going on. Stomping on the brakes could be a result of the movements of a seizure, or it could be because some idiot pulled out in front of you and you're trying to avoid a collision. Now, there are also seizures where, as I'm sure everybody knows, there aren't those abrupt movements. And one might think, well, there are systems that are designed to detect inattentive drivers. People are just staring off into space, maybe falling asleep, not paying attention to the road. And the question arises, would those systems detect seizures that simply involved altered awareness? And in talking to people who design these systems, the answer is, good question. Don't know. So that is something that is an open question at this point. Another thing that came up in discussions was the possibility of linking the car up to medical devices. There are some people who have various medical devices that are designed to detect seizures and warn them of them. Well, that has some technical challenges. Of course, there's communication protocols and all that. Those could be addressed. But there are also some social challenges as well. There are privacy concerns. There are government regulations. So while that is a possibility, it's not exactly trivial. Could be done, but there are some challenges. Now, the next question, if a person is found to have a seizure and they're driving, well, what should the car do? Obviously take over, but then what? Generally, people agreed it should pull over to the side of the road and stop safely. What then, though? And the answer is different people would need different action plans. And that also aligns with the fact that if the vehicle is driving itself and they have a seizure and the car detects it, what's going to happen? What should happen? People may or may not want the car to pull over. Some people said, yes, it needs to pull over. I want the car to pull over if I'm having a seizure. Other people said, no, not necessary. Some people said, I want this car to take me to the ER or to stop and call paramedics. Other people said, no, I wanted to call a trusted friend or family member. Maybe the car can send a text. It can get in touch with a mother or father, a brother or sister, a spouse, a child, someone that they trust who will know what to do and how to address it appropriately. Some people might want different actions in different scenarios. The vast majority of the time, the car should do such and such. But if I don't respond to some prompt within a certain amount of time, then it should take additional actions. And in some cases, some people said, it doesn't need to do anything. As one person said, I'll be fine in 5 minutes. It can just wait. Their only issue was if the car stopped at its destination and it expected them to get out before it left to go do whatever else it was going to do, that it might not wait for them to get out. That was a very, very simple thing. Just make it wait until it's verified the door has opened and closed. Now, there are some other interesting findings here. And one thing that came up in a discussion with one of the healthcare professionals was that some people who've had surgery to stop seizures still have a problem driving, because now it isn't the fact that they have seizures that stops them. They have limitations to their peripheral vision, and there's a safety issue. Now, there could be some technical solutions to that. Cameras are widespread in use on vehicles. Perhaps something could be done there, but it is an issue that, to be honest, I didn't know I was going to hear about. The cost of the solution is also a huge, huge concern. If you have a solution that's technically perfect, but it's expensive, well, that's a problem. People can't afford it. So one of the things that really came out was the affordability needs to be considered. How do we make the technology accessible so that those who need it can actually get their hands on it, and it's not limited to only a few people who have the money? And then safety is a concern, and that's not unique to this community. Everybody who knows anything about autonomous vehicles is concerned with safety. And then the question arises, when is it safe enough? We're never going to get to 100% with complete certainty, because there's always the possibility of that one weird thing happening. So does it have to be as safe as the safest driver? As safe as the worst driver? That's pretty bad, as the average driver? So that is actually a really big question. And something that we discussed in a lot of these discussions and a lot of these groups is, what would convince you it's safe? What kind of evidence do you need to see? A lot of people really want to see testing. They want to see test results. They want to know that it has been thoroughly tested in as many conditions as possible and that it's been shown to be safe. Theory isn't good enough. Documentation isn't good enough. The proof is actually seeing it work, but seeing it tested in a safe way as well. You don't just turn it loose and say, okay, let's see how it works. Now, next steps. All of this is great. It's really interesting. But what do we do with it? As an academic, what do we do to distribute cool, interesting information we find? Well, we write papers. So there's an academic paper and it's in process on the study. And that, of course, will be shared with the foundation when it comes out. That may take a while. Those of you who are familiar with the academic world know that the process, the wheels turn a little slowly. Now, part of this paper is going to be a roadmap of research and development avenues. Because if you think about some of the things that I said we found, there are some things where the technology exists. We want to have a system that will have different actions programmed in for different people. Well, that's programming. That's something we can do. The technology exists. An arrangement of cameras for somebody with limited vision? Sure. There's research and development work. In a practical sense, there's some testing, but there's not anything really new in terms of technology. But some of these other things, how do we detect the seizures in the car? Can we detect them fast enough? All of that is stuff that really involves further research, and that's going to be part of this roadmap. And then longer term, there are more studies that need to be done. And they're going to need to have a lot of people involved. Industry needs to be involved. Healthcare professionals, of course. People with epilepsy have to be part of this because you can't design a solution for people without really working with them to make sure that they are comfortable with it. Engineers, both in industry and in academia, and a lot of other researchers, computer science, economists have to be involved. A lot of other people have to be involved in order to make sure that the solution satisfies all the requirements. And I say solution, but really it's going to be solutions, plural, because there's always going to be different cases that require different things. And this is a continuing effort. Technology is not stagnant. There's going to be new sensors developed, new technologies, and everything has to evolve to make sure that it continuously is aligned to the needs of everyone, including people with epilepsy. And with that, I'll wrap up. I want to thank you for your attention. And I've got my contact information here if anybody would like to follow up afterwards.
Well, what a wonderful learning experience we have had so far. And I want to thank everybody who has been a part of these conversations. And of course, what's exciting is we have one more. So next, I am inviting you to this wonderful session, the Epilepsy Surgery Roadmap, Process and Procedure. And we know for some individuals living with epilepsy, surgery can be a meaningful improvement in seizure control and also quality of life. Of course, that journey to surgery is not an easy decision, and it's something that we do with deliberation. It's a thoughtful process filled with key decisions, evaluations, connections with our healthcare providers, and in fact, a collaborative team every step of the way. And our panel is going to demonstrate that today. So this session is proudly sponsored by Trinity Health, and we are joined by a team of experts from Trinity Health Grand Rapids who will guide us through the full landscape of epilepsy surgery. So we thank you for that sponsorship and, of course, your wonderful care for patients. So you're going to hear from Dr. Hussam Shaker, who is an adult epileptologist, Angela Saru, who is an epilepsy nurse navigator, and Corinne Ponstein, who is our neurosurgery nurse navigator. And looking forward to hearing from you all. So we're going to walk through what that process is like, what patients and families can expect, initial assessments, testing, post-surgical recovery. And we're going to also look at advanced diagnostic tools like stereotactic EEG, often called SEEG, and the breakdown of surgical options available. So we're going to go through some of those today. And most importantly, we're going to talk about how care teams can support individuals and families through every stage of that process, offering not just clinical guidance, though of course that, but compassionate support too, in what can be a life-changing journey. So we're glad you're here to learn with us. And now I'm just going to welcome our incredible speakers. Thank you all for being here today. Great to have you.
Thank you, Renee.
Amazing. And to begin, I'm wondering if you can each share a little bit about your role, how you support individuals who are exploring that possibility of epilepsy surgery. Angela, I wonder if we might start with you.
Sure. So thank you for the introduction. I'm Angela Saru. I'm the epilepsy nurse navigator here at Trinity Health. I do a lot of patient education, and I support both of our physicians and the patients and their families. A lot of what I do focuses on making them feel comfortable and understand all the different steps, because it can be kind of convoluted, and it's not exactly a direct pathway always. It sometimes can take time, and they start and stop, and as they're working their way through the process of whether or not they want to go through with it or not. So I go through all the different tests with them. They've been talked about, obviously, with their providers already, but I kind of help them understand it in a less scientific, terms. So I do that, and then I make sure that they get scheduled and that the results come through. And then once we do have all the results, that information gets to the providers so that they can be presented for surgery.
Important, not leaving people on their own, but really accompanying them through all of the language and making that accessible and meaningful as they deliberate. And also, just having an emotional guide, someone to really care. So thank you for all that work you do. And Corinne, how about you?
Yeah, so I am Corinne. I am the neurosurgery nurse navigator. So I kind of come in once they have decided that they want to take that next step towards epilepsy surgery. And initially I speak with them. We kind of find a time for them to come in and discuss surgery with Dr. Luters and answer some general questions kind of about what to expect during that consultation and kind of timeline and next steps moving forward.
Amazing. Thank you so much for that. And just grateful for all that care you provide. And of course, Dr. Shocker, you're present throughout the whole process and inviting people even to think about this. So can you tell us a little bit about your role and what makes this important for you?
Yeah, thank you. Thank you for the invitation. So I'm epilepsy physician here at Trinity Health. I'm now currently the medical director of epilepsy department and surgical epilepsy program. We started this program in 2020. It was like a dream. We got all these pieces together. I have a great team to help me build this program. So now I cannot believe it's almost 5 years now. We started in August 2020. I did my training in epilepsy. Then after that, I was like very amazed by the epilepsy surgery. So I decided to do another fellowship for surgical epilepsy in Cleveland Clinic. Then in 2020, I brought this new technique and a new methodology about surgical epilepsy, the way we understand epilepsy a little bit differently from the past, to Trinity Health, and we have been doing very, very well here in West Michigan.
So exciting, and thank you for creating this program and all that it can do for people. And of course, this is the Epilepsy Innovation Roundtable, so this is innovation, right? Just that we're continuing to find new ways to treat epilepsy and increase and deepen all the quality of life areas that people want to have. And I think that's really, really wonderful. Also, Dr. Shocker, we know medications are the first line of treatment, but not everyone experiences full seizure control. So under what conditions would you begin your evaluation to see if someone might be a good candidate for surgery?
So yes, it's a good question that people ask when I can go to surgery, when I should know that, okay, I have to give up on medication or I cannot get seizure freedom. So I can say in general, almost every patient will respond partially or completely to medications. We have a big trial in 2000, 1999, 2000. The first was like a big randomized trial about when patients are going to stop responding to medication. So we found, and we still have the same data up to now, that I introduced the first medication, I have 47% chance that the patient will be seizure free. I add the second medication, I add 13%. Then from that point, regardless the name of medication, I will add the chance will be 4%. So I'm talking about 36 to 40% of epilepsy patients, they don't get seizure freedom on medications. Yes, we have more than 30 anti-seizure medications. They might improve some life quality here and there, but I'm almost ending up with 1/3 of epilepsy patients, they do not have seizure freedom. So that's the first rule that we use. The other rule that we use to go to the surgical route, if I see abnormality on the MRI, if I see a lesion or abnormal tissue in the brain on the MRI that can explain the seizure. So it tells me as long as the lesion is there, most likely the patient will continue to have a seizure. So these are the criteria that we use to go to the resective surgery. Now, at the end, we might talk about the modulation or modulative treatment. The same thing, if they don't respond to medication and I cannot resect for multiple reasons we can talk about, then we start talk about surgical route, and we talk to Angela and Corinne, and now we start to put things together. We need to do a lot of tests to go to the next step to see if the patient is a good candidate for surgery or not.
Thank you. That's really helpful. And to Angela and Corinne, from your perspectives as nurse navigators, how do you help patients and families understand that surgical evaluation process? How do you break that down for people? And of course, how do you prepare them emotionally and practically for each stage? Yeah. Maybe we can start with Corinne or
Sure.
Yeah, let's start. Yeah, sure.
Yeah. So typically, after they come in and they meet with Dr. Luters, I take them and I sit down with them and their support team, so their spouses, their families, and we kind of walk through the next steps. So first, we will discuss a surgical date, and then we kind of go through what's going to happen leading up to those dates. So one thing that they need to do is, they meet with our surgical optimization team, who kind of goes through a very thorough health history, and we'll have them come in to ensure that they are medically safe to go through surgery and anesthesia. And then we also discuss imaging that needs to happen prior to the surgery. It's just kind of a time for them to talk through some nerves and questions and concerns that they have, emotionally. It's a big change. It's a big step. So everything from, a lot of times females are even concerned about having to shave part of their head. And so even just having a space for them to be able to say, this is one thing that might seem silly, but I'm kind of concerned about this, and just being there. And then practically, having the talks about how much time off of work am I going to need? And am I going to be able to care for my children afterwards? And am I going to need help at home? And so just providing a space immediately after meeting with Dr. Luters for us to kind of start those conversations and kind of work through some of those things.
I really appreciate that. And I'm sure patients do too, because first of all, these are common questions, and you probably can mirror back to people like, oh yeah, people ask that a lot. But of course, we talk about epilepsy care and quality of life and all of these facets, childcare and employment and just kind of the rhythms of life. So thank you for being present to that. And
Yeah.
Angela, you're doing this work even before someone has decided surgery. So yeah, how does that process kind of work for you?
Well, it kind of depends on the patient. So we meet them at the level of where they're at in this process and what concerns they have. So, some of my patients I might talk to weekly because they just need that constant reinforcement about what questions and concerns and worries they have. Sometimes it means we're praying over the phone together so that they feel comfortable with what's going on. Other times they just want straight stats, statistics, data about what's going on. Other times they need to be able to visualize what's going to happen. So I try to give them that picture as much as possible. I also help them with some of the other, basic things like, how much is this going to cost? What's going to happen when I'm off of work? So we're talking about their FMLA paperwork. We're talking about their short-term disability. We're talking about, what resources are available in the community, or getting our social workers involved to try to help alleviate some of those other concerns. Obviously, with epilepsy, there's always the limitations that epilepsy has on the person, from driving to work and all those different things. So when you move on to surgery, it's another level. But the thing about surgery is it's a short-term thing, right? So we talk about that and that light at the end of the tunnel. So we work through it as they need to and what they need to. So
Yeah,
just at their level, when it's whatever they need.
Very individualized, which is wonderful. I mean, that's what care should be, for the whole patient and for the specific patient. And I also love that community approach that you have social workers involved. And of course, they're connecting to community organizations and resources even beyond the hospital. And that's really great. Dr. Shocker, a question for you as well. We know one common form of epilepsy surgery is resective surgery. So can you share what that entails and what determines how much of the brain tissue is removed?
Yes, it's a great question. So before we go to the surgery, we do, as I mentioned, what we call a pre-surgical workup. So we have Angela is in charge of that to make sure we have a lot of boxes to check. We need to understand the semiology of the seizure. We need to understand the EEG of the seizure. We need to understand imaging, MEG, SPECT. Then we put all these informations together to come up with a full understanding of the epileptic network. So we meet every Friday to discuss. We meet all epileptologists, neurosurgeons, Dr. Luders, neuropsychology. We have 2 or 3 physicians with us. Sometimes neuroimaging. We have SPECT, MEG specialists. So we discuss the case. Then once we know we have high chance and we understand the epilepsy, but we need tiny details about, we know it's A, B, C, but did it start in A, went to B, or it start in B, went to A? Then I go to stereotactic EEG, where I place electrodes inside the brain to know exactly where seizures are coming from. So I'm not guessing here. There's a way how to interpret the SEEG. So I see it starts here, it goes here, then it ends up here. Every epilepsy patient have what I call their own highway. They all use specific highways in the brain. Then we go to stereotactic EEG. I see these highways, and before I finish the SEEG, it takes about 10 days. I stimulate that area, that highway, and I trigger seizure. So it gives me a peace and comfort that I found the spot. Once we find the spot that epilepsy starts from, then we meet again, the whole group. I'm going to show them the new data, the surgical data. Then we decide the network. After that, the biggest question will come to us, can I resect it or not? That's the first question, because I told you medication after a certain point, it's only 4% chance. If I go to the surgical route, all data showed between 60% to 80%. So I'm talking between 4% seizure freedom to 80% seizure freedom with resective surgery. So is that tissue very important to the brain? Is that tissue what we call eloquent cortex? Like, is it hand area? Is it vision area? If I resect it, patient will end up with a huge deficit. Was that tissue already burned? Because like sometimes the hippocampus memory area, when we do memory test, the memory is not there. The memory is being very affected. So that gives me high chance to go there and remove it because the injury already happened. So to decide I'm going to resective surgery or not, it depends on the epileptic network. Is it small or big? If it's a huge area, 3 different areas, I don't want to go and remove 3 big areas in the brain. So it should be meaningful surgical outcome. It's not just to stop seizures and then the patient had a lot of deficits. So first of all, I should understand the epilepsy where coming from. Number 2, can I resect it? Can the surgeon go there? Number 3, if I resect it, does it produce a deficit or the patient will be much better because I'm stopping seizures, so the memory will be much better. The language will be much better. The mood will be much better because the number of seizures going significantly low. So a lot of factors play a role when I'm going to go to surgery or not. But that's my first strategy. I like to find resective area because that what showed so far have been shown to give patients seizure freedom, like 80% seizure freedom compared to 4. It's a lot.
Yeah, it's a big jump up, and I can see how, looking at the individual patient and just trying to find that highway and how that can take some time, but also that specificity can be so transformative. And speaking of that, you have to do a lot of diagnostic tests to figure out how to find where that highway is. And I'm just wondering if you can tell us some of the diagnostic tests that are typically used. And I know like SEEG is a real passion area for you too, if you want to say a little more about that. And how do these guide your recommendations for next steps?
Yes. So first of all, we need to admit our patient to epilepsy monitoring unit. That the work will come from Angela and Corinne to work on insurance. So we need to record at least 2 to 3 typical seizures. I need to see patient seizures. We sit and analyze this seizure. We have a methodology called anatomo-electrical imaging or correlation. So we try to see where it exactly start, what happened with the EEG, what happened with the MRI. Then after that, we do very high quality MRI, 3 Tesla, where we have 1 millimeter thickness of the MRI compared to the stroke MRI with like 5 millimeter. Every time you scroll, you miss 5 millimeter. In epilepsy, we do very high quality MRI to see if there's tiny lesion we cannot see on regular MRI. Then we have another test called the SPECT, where we have a nurse to sit next to the patient. Once the seizure starts, the nurse will inject a dye. It's called TC99. Then we take an image of the brain and you see where the dye go to the hyperperfused area in the brain because the seizure area require more blood. So that that dye will go there. Then we take an imaging and we see the network to help me where seizure start, where seizure end. Then we have a very advanced technique that we do in Helen DeVos. We work with Dr. Ferrari. We do a MEG to look to a magnetic field of the epileptic discharge or potential epileptic discharge. We do memory tests for almost every patient to see where are we now. If I do a surgery, what's the baseline? If the baseline is very low, that will give you more encouragement to go and do resective surgery. If the patient has like normal memory, I have some patient like normal memory, they are teachers or do very high functioning job, I will be very careful with these patients. Once I understand everything, we put a map where we're going to place electrodes for SEEG. So when I will go back, when I do scalp EEG, with like 99% of people do scalp EEG. So I'm looking to the abnormal electricity from the far. So I have the bone is a barrier. So it filters out a lot of activities in the brain. When I go to stereotactic EEG, it's a methodology where I'm looking to the brain from 3D. So I look from 3D around the brain, and I have the software for that. So every area in the brain, I put electrode. I know where's my electrodes mesially inside the brain and laterally at the cortex. So every electrode has between 8 to 18 contacts, each contact in a specific area in the brain. And we know exactly where this area. We have a software to show me the electrodes inside the brain. Then we start to record seizures. We stop medication or decrease medications. We record seizures while the electrode inside the brain. So most patients, they tolerate the SEEG procedure very well. You know, I had a patient, maybe Angela knows, like we did the surgery at 8 a.m. I came up at noon, I saw him playing a Nintendo. I said, man, like you have 15 electrodes inside your head. So people in general, they tolerate it very well compared to previous surgeries where we had to remove the bone, patient would be very toxic. No, in 2-3 hours, patient will wake up, will talk to us. It's in general painless, except the first couple of days where, because the muscle tense, they have some jaw pain when they open the jaw or try to eat. Next day, they will be much better. Then we will keep them in the unit for about 10 days. Before we send them home, we do the test I told you to trigger these seizures to know I got exactly the spot, so I can trigger it, exact seizure. And I do functional mapping. So I trigger this area in the brain. I give the patient paper to read. If the patient stop reading, I know this area for reading. I'm not going to touch that area. If I touch the area and the hand moved, I know this is the hand area. So I'm not going to touch that area. I'm not going to resect that area because I know if I remove it, patient will have deficit. So at the end, putting all this information, like phase one, what we call phase one before SEEG, it's very important. It's very important to understand every epilepsy. It's very important to know that there is high chance of seizure freedom before I go to SEEG. I don't go to SEEG and put electrodes and pray that I hope I find the spot. No, I am very determined that the spot between A or B, but the SEEG will tell me where it starts, where it ends.
Yeah, that's really, really helpful. And again, it's just, a reminder, everybody's brain is unique. And thank goodness we have these diagnostic tests and, of course, all the expertise to view those tests and to understand what's happening. For our nurse navigators, what are some of the most common fears or concerns that patients express when they first hear that surgery might be an option? And how do you approach those conversations with compassion and clarity? Yeah. Angela, do you want to go first?
Sure. I think the thing I see most frequently is people are very fearful of the brain being messed with. The possibility of removing a chunk of the brain and not understanding what that means and what that looks like, as well as what could happen. A lot of patients have a fear that anytime you mess with the brain, they're going to die, which is, a legitimate concern. Technology has advanced greatly over the years, and we just try to go through and explain to them that things have advanced, that although there is risk, always going to be risk when you're doing a surgery, and what those possible risks are, we go through and let them know that, we've had really great outcomes, shown that what we're doing, we're very good at, that our surgeon that we work with, Dr. Luters, is very efficient, very well trained. So we try to make them feel comfortable with our team and the success that we've had. And then we start then whittling away their individual concerns that they might have.
That's great. I'm just thinking about how important it is to have FaceTime with everybody who's going to be a part of this process, right? So there are no unknowns, in terms of the medical pieces, or the process, but also the relationships. And I think that's really great. Yeah, and Corinne, how about you? Like, what are some common things you hear?
Well, I think, like Angela spoke to earlier, every patient is so different. A lot of it is the medical aspect of it. Like, this is a big surgery, and so we talk through. We make sure that medically you are safe to have this surgery. Your heart and lungs are safe. You're strong. You're going to be, we're going to get you through this. And then it is a lot of what to expect afterwards. Like I said before, how much time off of work am I going to be able to take care of myself? Even the financial aspect of it. So we talk through that. We are going to make sure that we have all of your insurance authorizations set. You're going to, everything is going to be taken care of in that aspect. And then it's just a lot of, I think, just making sure the patients know, they leave with my phone number. They can use my chart. We're talking back and forth all the time with these patients, and just anything that comes up, send me a message, give me a call. We're around. This is what we do. We're here for you. So making sure that they know that line of communication is always open.
That's so lovely to have that open. And I'm sure even down the line, 6 months, a year, sometimes people may have unique questions. Is that often the case?
Yeah. Yep. I get that a lot, where it's, 1 month, 2 months, 6 months later, they're like, hey, I'm still experiencing this. Is this normal? Is this okay? And so, if it's something that I can answer, fantastic. If not, I can take it back to Angela and Dr. Shocker and Dr. Luters and say, hey, can we revisit this? What are your thoughts? And ultimately, get the patient settled and know that they're doing okay.
Yeah, best part of being on a team, right? You've got each other. Yep. Angela, were you going to say something else?
Yep. Through this whole process, we really develop a very tight relationship with all of these patients. So they learn to trust us. They learn to trust their team. And they have constant contact. They have our direct phone numbers. I've had patients call me on the weekend, like in the middle of my brother's wedding, and we just walk them through whatever their concerns are at that time. So we are a lifeline to them, and that's what we want to be. So we're there for them. The other thing I think that's helpful is they know that our goal is to give them their best outcome. And we're not pushing surgery. We're not pushing numbers. We're not doing this. We are gearing their care towards them. And I like to explain to them that we are going to do the least invasive thing to get the most efficient outcome for them. And that's helpful for them to know that.
It's huge, right? Yeah, just to know that the care is being driven by their needs. That's just huge. So thank you for that. And I'm just thinking about how, surgery and patient care touches different parts of life. We've got Nintendo and in the hospital, we've got weddings. It's wonderful. Dr. Shocker, another innovation I definitely want to talk about. We've already talked about resective surgery, so that's removing a small amount of brain tissue. But another innovation is laser interstitial thermal therapy. Feels a little bit like a tongue twister. But sometimes that's called laser ablation. And I just wonder if you can share how that procedure works and, in what situations might that be preferable to a traditional resective surgery?
Yes, it's a new technique came to us. We love this technique, and most patients, when we talk about surgery, they are very interested in this technique. With this technique, you don't need to open the brain. You can use just the same trajectory that we use for stereotactic EEG. So we have the same robot, we have the same electrodes that we know where seizure is coming from. So instead of Dr. Luder is going inside the brain and remove the bone and go do craniotomy, then we can use exactly same trajectory to go to that area under live MRI. So the chance of making mistakes by going off the target is very, very low. And we control the temperature that's gonna burn that area. And we know what to expect in 2 months, in 3 months, because the effect does not happen right away. To go to that technique, again, I need stereotactic EEG to do first to understand seizure and then find areas that it's very small. I don't do laser ablation for a huge, big area in the brain. It should be limited area in the brain that I can target, that I know seizures coming from that area. We have difficult area in the brain to access. We have areas very deep, like, for example, insula. Insula is very deep in the brain, and we did not have access for it for years. Even the understanding of epilepsy is like changed after we have access to amygdala and insula. So these areas very deep, and in the past we did not have electrode there to record their people's seizures. So cingulate, insula, we prefer to do laser ablation, especially insula, because when you show stroke physician the insula and how the middle cerebral artery like surrounding insula, it's wow. I'm not going to touch that area. Surgeons will not touch that area because it's very dangerous. But when I go with laser ablation with 2 millimeter thickness, going to that area, it's relatively safe, and we do it now more frequently. And very importantly, recently we had the technology to take a biopsy. In the past, one of the downside of doing laser ablation that I don't get the tissue. I don't know what the pathology. Is it a tumor? Is it cortical dysplasia? So I laser it without knowing what was the initial pathology. If seizure is coming back, I don't know what was the initial seizure mechanism. Nowadays, we did last month, we did our first biopsy for a patient came from the east, came to us, and before we did laser ablation, we went there. We took a small tissue, and it came back like low-grade tumor, like ganglioma. So now it's not only giving me the effect of treatment, but it's also giving me the diagnostic tool where I can understand the pathology of the tissue that causing seizure before removing that tissue.
That is huge and innovation, absolutely. So that's great to hear. Another question for just different techniques and types of surgery. There are neuromodulation techniques like VNS, RNS, DBS. Those are also surgical, but they're less invasive in many cases. And we actually discussed that quite a bit in our first session today, but I wonder if there are any brief insights you'd like to share when these devices might be considered over resective surgery or laser ablation.
Yes. If I cannot remove the area or laser it because it's very, very important, eloquent cortex, as I said, hand, memory, language, vision, auditory, hearing. So these areas very important. If I remove them, patient will end up with big deficit. So this is the first scenario I'm using neuromodulation to reduce the number of seizures. If seizures coming from both hemispheres, like I had patient when I found 50% from the right and 50% from the left temporal regions. I cannot remove both temporal regions. So if I feel 90-10, yeah, I will do maybe surgery for the 90% and I keep medication for the 10% of seizures. But if I feel it's 60-40, 50-50, we will go to neuromodulation. Recently, and this is like a big advancement also recently, for generalized genetic epilepsy or Lennox-Gastaut syndrome, these seizures, they come from both hemispheres. In the past, we never had any surgical options for them. Nowadays, we can put neurostimulation in both like specific thalamus nuclei. So we have now we have VNS, RNS, DBS. So VNS was approved 1997, RNS in 2013, and DBS in 2018. So every patient we have that we think resective surgery is not an option for them, we discuss in our team what's the best modality for them. So the VNS, I'm sure we talk about it. It's like in the chest here. It affects the vagus nerve. RNS, the leads going inside the brain, but the battery is the back of the brain. DBS also is going inside the brain, the leads, but the battery in the chest. So this difference might make big difference for some patients coming from Upper Peninsula. Like I don't want to bring them every 3 months to do a specific modality. Maybe I can do other modality. I can control it from far. I don't need to bring them to drive 7 hours or 8 hours a day to every 3 months to do the programming. So it depends on scenario, what kind of epilepsy, what kind of semiology, age, comorbidities, they all play a big role in deciding this neuromodulation. With neuromodulation, for years, we've been talking about only reducing seizure numbers. Last month, we had a data that we have 24% of patients, they achieve 6 months seizure freedom or something like this. So now we are talking about short period of time seizure freedom. In the past, we did not have this data.
That is incredible, right? I think is a good reminder too that because these devices and these neuromodulation techniques are relatively new, we're getting more data and people have had them in use longer, right? So we can see especially how those responsive features are creating some of these effects, and that's absolutely incredible. So wonderful to hear. Yeah, another question also really to all of you, but what kind of resources or decision aids do you provide to people when patients and families are weighing those options? What sort of materials do you hand over and what kind of content might be there? Angela, could we start with you?
Sure. We've got individual, patient education handout for just about everything, from each test, the ICTOSPEC, the SEEG, there's one specifically on if we're looking at neuromodulation, what are those possible neuromodulations and the pros and the cons of each one, so that when they're making those decisions with their doctors, they can kind of, weigh the benefits of each one. We also have nurse educators are available with some of the companies that make those different modulators, as well as patients who have them who can actually talk patient to patient, so they can have that experience and be able to ask those more important, like, livelihood kind of questions from their own personal patient experience too. So that's available. We also have information about their billing, their CPT codes and stuff like that, so that they can address that information as well.
Yeah, that's great. And Corinne, what sort of things do you provide?
Well, Angela pretty much hit it all. Yeah, there's, we have social workers too that are available to help. Whether it's with finances or just, community resources after surgery, that kind of thing. So yeah, lots of different resources. Sometimes it's even just being a sounding board with patients and talking through the different options. They might meet with Dr. Luters, who can discuss a couple different surgeries, and then a lot of times even the families don't all agree. The support system doesn't, might want something different than the patient. And so just kind of, even just being there for them to talk through that and, kind of, like I said, be a sounding board and just say, well, what I'm hearing from this person is this, and, they're feeling like this, and just, helping them work through it.
Yeah, I really appreciate that. And I think really throughout our whole conversation, we've been talking about like the uniqueness of each patient and their family as well and what they need. And I'm just thinking, sometimes having that sounding board and being able to make a quick call or put something in my chart is what they need. But other times someone's like, I need to go home and feel like I'm doing my research, right? We all learn differently. We all access this information in unique ways. So I think that's really lovely. And let's talk a little bit more about recovery. I know, you've mentioned some of this already, but what are some ways you support patients and families immediately after that surgery and during that recovery process? And what do you most want them to know in that phase? Dr. Shocker, I think I might actually start with you on that, and then we can also talk to our nurse navigators.
Yes, for patient, it's a big deal to do a brain surgery. I always think, if I have family members having brain surgery tomorrow, how I'm going to sleep today, what I'm going to think today, what my thinking today, what the level of anxiety. So we understand that it's not an easy decision. And that's why we decided that every patient, before they go to surgery, to meet with me or one of surgical epileptologists. So just to go over questions. So Angela knows, like, she has to schedule all SEEG patients with me or other epileptologists, to make sure that the patient fully understands the process. We don't want surprises that patient thinks they are coming for 1 day or 2 days. So we have 1 hour for every patient, just that visit, to explain the technique, what to expect. And then we send them to Dr. Luders for another hour to talk about the surgical techniques, potential complication. It's a brain surgery. In the hospital, me and Dr. Luders, we meet the patient before they leave. Also, we give them the expectation. We say, hey, take it easy the first 4 to 6 weeks. We remove electrodes most of the time bedside, but we tell them, try not to move your head like quickly. Take pain medication, take maybe some steroid for the headaches, because maybe 15 or 20 electrodes were inside the brain. Then they have, after that, most of the work will be on the surgical team, Dr. Luder's team, because patient will deal with if there's any side effect from the surgery itself, not from the medications or from the seizures, but it's from the surgeries. Most of the time people, hey, I have headaches 5 of 10. Is it fine? Should I do CAT scan? So in the first 2 to 6 weeks, we are very vigilant about any message from the patient, and we tell them don't hesitate to call us for anything. We help them with their employer if they need to stay off. We try with FMLA. They have appointment with Dr. Luders to see their stitches, to see the wounds. So the first 4 to 6 weeks, we keep our eyes on any message from the patient. We try to give them confidence. Then we see them within my team 2 to 3 weeks after I present them. So I present after I get all data within 2 weeks of discharge. So I see them again, or their primary epileptologist. They see them again to discuss what options do we have for surgeries, what the SEG final agreement was. So we keep the patient in the loop. They don't feel that, okay, we did the surgery, we went home, no one is caring about us. What's next step? What's going to happen next? Is my headaches going to go away? I feel dizzy. So it's not an easy process, but we try to have a team for that between Angela, Corinne, Dr. Luders, and me.
Yeah, that's so important. And right, just people don't feel like they're left on their own after this and not knowing what's typical or what might be needed. So that's really helpful. Corinne, anything you'd like to add on that?
Sure. Yeah. So just a lot of times, when they're in the hospital, I will go and follow up with them even before they discharge from the hospital. And it's a lot of like, look, I know you've had a lot of information given to you, leading up to this, and it can be a lot to take in. So, what are your concerns today? What have you thought of today? As far as going home, do you feel like you're ready? Do you feel okay? What can we talk about with that? And then afterwards, when they do go home, it's, I like to make phone calls to them a lot of times, even before they think of something, just because, you'll call and they'll be like, oh my goodness, I'm so glad you called, because I didn't think this was a big deal and I didn't want to bother you, but I'm having these headaches, or if I do this activity, it gets worse. Is that okay? So, even just reaching out ahead of time before they get concerned and worried, and just say, hey, we're thinking about you, we're checking in on you, how are you feeling? So a lot of times I think that helps them, even just to know too, okay, I can call with things, I'm not bothering them, this is what they're there for. So yeah, we
people really worry about that. It's like, no, wait, this is why we're here.
Yep, they do. So
good, that's awesome. And Angela, you mentioned such a wonderful community approach, and I'm just wondering, how can the broader epilepsy community, folks who are going through surgery, have family and friends and peers and coworkers, and how can the broader community or family support someone who is recovering from surgery?
Well, I think that depends on the patient,
Sure.
But I personally am reaching out to them after their surgery, within 2 days after their surgery, over the phone from being discharged from the hospital. And usually at that time, I have their caregivers on the phone with me as well. So it's a patient, it's a direct family member, whether it's a spouse or, a sister or a mother, and they have questions at this time too. So at that time, we're going through that kind of stuff. If they have any concerns, if they're sometimes they're like, I feel like maybe he's a little confused or he's a little sleepy. So we address that right away. Or if they mention that they feel like the patient's not speaking well, then we start looking into addressing that right away with speech therapy. So we help them through that process. As far as what the caregivers can do themselves, the biggest thing is looking for signs of infection, making sure the basic needs are met. Maybe providing a meal, making sure they don't have to do that on their own so that they can rest and they can recover. And then always helping with transportation to and from their follow-up appointments.
So great. And, just encouragement for all of us to care for the caregivers, right? And just to make sure that community of support is broad and present. So wonderful. This has been an amazing conversation. And I'm wondering, just kind of as we are wrapping up here, if you have any closing thoughts or words of encouragement you'd like to offer, right? This is just a wonderful chance to let people know that you're here and just what encouragement you might provide. Corinne, can we start with you?
Yeah, I guess just, we know it's scary. and like I said, every person's needs are different, but again, this is what we do day in and day out. So we love taking care of these patients. We love making sure they have what they need and that they feel safe and confident in the team here. So just I guess knowing that nothing is too little. Please, any question, any concern, yeah, we're always here. So from beginning to end, from the, what does the workup look like to how am I going to feel 3 months afterwards? We're here with them the whole way. So.
Awesome. Angela, what would you say?
I would encourage them to really think about it. It's very scary, but what I've seen on the other side of this is life-changing for a lot of patients. People who've never been able to drive in their lives and they're 40 years old, all of a sudden being able to get their driver's license and be able to drive on their own because they've not had a seizure in a couple of years. Seeing people be able to establish families because they haven't been able to because they were so burdened with their seizure load. Having people be able to actually hold jobs where they couldn't keep one before more than a couple of months because of all of their seizures and their call-ins and so forth. It's life-changing for people. And if they put their faith in us, we will do what we can to guide them so that they can have their best outcome too.
Beautiful. Dr. Shocker.
Yes, it's nothing better than getting patients seizure-free after surgery. We had amazing stories. One time with my wife, we were in the restaurant and the guy came to me and said, "Hey, Dr. Shocker, I have been seizure-free 8 months the first time in 20 years. I'm now driving." So that, it's very rewarding. We had patient, as Angela said, they got engaged after the surgery because they were unable to do anything. Last week, we had a patient, Angela knows her. She was 19 years old. She was home on her couch. Can you imagine that for like 2-3 years, seizure after seizure, and now seizure free for almost a year. Like the parents came, the family came. She looks different. She looks like a new person. She's back to college. Everyone is happy. There is hope for people who are suffering from seizures. We will do our best to get people seizure freedom. If we cannot do it, we will tell them this is the best we can do for you. This is the best medication you can use. But if we have a chance to get them seizure free, we will do with no hesitation.
Yeah, seizure free if we can, and improvement is in all the ways that we can. Yeah. And I just thank you all so very much. I think that's beautiful. It's a good reminder that this is about medicine, yes, it's about surgery, yes, but it's about life, right? Yes. And that's really coming through today. And thank you for your whole team and all that you do and all the ways that you care. It's really extraordinary. And as we get ready to close, I also have the great privilege of saying that we are here for you. That is the Epilepsy Foundation of Michigan. We're here to connect your resources, be an accompanying guide and friend on your journey. We feel the same way. We are here to help you have the best medical outcomes possible, but also the best quality of life possible. We want that. And we are able to do what we do, including having this conference, because of our presenters, our speakers, and our sponsors. We're so grateful for that. So I'd like to thank our generous sponsors one more time. Our community sponsor, Trinity Health, that has sponsored this session and made this conference possible. And our presenting sponsor, UCB Pharmaceuticals. I'm grateful for that as well. And we'd like to thank all sponsors for making what we do possible. And after this presentation, stay tuned to learn more about our sponsors. You'll see that next, and about our programs and services available for you. We want to bring community to you and you to community. So thank you to you, everyone who has joined us virtually. It means the world to have you with us. You're not alone on this journey, and we're grateful that you spend time learning with us and connecting to us. So as we finish, we thank you for your presence. And being in community with you, whether that's near or far, it reminds us of the strength, the resilience of the epilepsy community. And we want to hear from you too. So please take a moment to complete our event of evaluation. You're going to see that in the notes. This is a valuable way for us to learn from you and to know what sort of needs you have and what programs might be most helpful. So the link is going to remain active through June 2025. And you'll find the QR code for that on this YouTube channel. So thank you again, everyone. We're here for you. Just please stick around and learn more about what's coming up in our community, including our strolls for epilepsy happening all across Michigan this summer and every year. So we'd love to see you there. Thank you so much. Take care, everyone.
Thank you.
Thanks.
We at Team UCB Michigan are happy and proud to support your epilepsy journey. My name's Tara, and I walk to spread the word about epilepsy and fight its stigma.
This year at the Stroll for Epilepsy, I am walking for my 2 cousins, as well as all of those members who are spreading awareness for the epilepsy community.
I walk for my niece, Nicole, who lives in Canada, is on 3 medications, and is well controlled. She's 25 years old now, driving, and a vibrant young woman. That's why I walk for epilepsy.
Hi guys, my name is Inga, Team UCB. My why always has been and always will be my grandma. And reminder to all, be kind to yourself and try to find one positive thing each and every day. Cheering y'all on.
I walk in support of the patients and their families in the state of Michigan who suffer from epilepsy on behalf of UCB.
Hi everyone, my name is Jay. I am a senior executive provider liaison with UCB, and I belong to a great family called the Great Lakes region here in Michigan. The reason I do the Michigan Epilepsy Walks is because of my good friend Mark and his beautiful daughter Katie. May God bless all of you. Cheers.
Hi, I'm Hussam Shakir, an epileptologist at Trinity Health. Here are our 6 features of our top-ranked epilepsy program. We are level 4 designation of a National Epilepsy Accreditation Center. This is the highest possible designation to receive. Our inpatient epilepsy monitoring unit maintains our ABRT accreditation, a sign of high-quality diagnostic center. We offer robotic assisted surgery, including laser ablation, limited resection, or neuromodulation. Our highly regarded team, including epileptologists, neurologists, and neurosurgeons. Our team is with you throughout your journey. Social worker, neuropalliative care, and nurses. Everyone works together to navigate life changes. Our goal is to have you live fuller active life. To connect with nationally recognized programs, visit trinityhealthmichigan.org/epilepsy.